Good morning, dear BCMCH family. Welcome to Quest. And this week, again, we have a very interesting and intuitive session. And before we welcome our speaker, may I request Reverend Father Thomas Verghese Achin, our chaplain Achin, to start with a word of prayer.
Let's stand together. In the name of the Father, Son, and the Holy Spirit. Amen. ഞങ്ങളെ സ്നേഹിക്കുന്ന ഞങ്ങളുടെ സ്വർഗസ്ഥ പിതാവേ, ഈ നവംബർ മാസത്തിൻ്റെ 4-ാമത്തെ വ്യാഴാഴ്ച ഞങ്ങൾക്കിതുപോലെ ഒരുമിച്ച് കൂടുവാൻ ദൈവം ഞങ്ങളെ സഹായിച്ചതോർത്ത് നന്ദിയും സ്തോത്രം അർപ്പിക്കുന്നു. കഴിഞ്ഞ എല്ലാ വ്യാഴാഴ്ചകളിലും ദൈവം ഞങ്ങളോട് കൂടെ ഇരുന്ന പുതിയ പുതിയ കാര്യങ്ങളെ കേൾക്കുവാൻ, പഠിക്കുവാൻ ഒക്കെ ഞങ്ങൾക്ക് സാധിപ്പിച്ചതോർത്ത് നന്ദിയും സ്തോത്രം അർപ്പിക്കുന്നു. ഇന്ന് ഡോക്ടർ സുജിത് ഫിലിപ്പിനെ അവിടുത്തെ കരങ്ങളിലേക്ക് ഏൽപ്പിക്കുന്നു. പ്രത്യേകമായൊരു ട്രെയിനിങ്ങിന് ശേഷം പുതിയ പുതിയ കാര്യങ്ങൾ കാണുവാൻ, കേൾക്കുവാൻ, ചെയ്യുവാൻ, അത് ഞങ്ങളിലേക്ക് പകരുവാൻ ഇന്നത്തെ ദിവസം ഉപയോഗിക്കുന്ന ഓർത്ത് നന്ദി. അത് മറ്റുള്ളവർക്ക്, പ്രത്യേകിച്ച് രോഗികൾക്ക് ഇനിയും വരുന്ന ദിവസങ്ങളിലൊക്കെ ഒരു വലിയ അനുഗ്രഹമായി തരുവാൻ ഞങ്ങളെ സഹായിക്കണമേ. വന്നു ചേർന്ന ഓരോരുത്തരെയും അനുഗ്രഹിച്ചാട്ടെ. യേശു ക്രിസ്തുവിൻ്റെ വിലയേറിയ നാമത്തിൽ തന്നെ. ആമേൻ. പ്ലീസ് ബി സീറ്റഡ്.
Thank you all for coming. Before we start, I would like to make a little announcement. We are expanding our hosts for Quest program. So anyone who is interested in hosting this program, starting and ending of this program, just like I do, please share your interest with me. We want to form a team of hosts who will conduct this program. So thank you so much. So today's speaker, he did MRCP while he was doing LKG in school. For M, he learned meticulous. For the letter R, he learned the word rigorous. For the letter C, he learned the word competency. And for P, he learned precision. That is what Dr. Sujith Philip, Senior Consultant in Gastrosurgery, is known for. We did listen to his talk previously. Brilliant orator, training himself in the best institution in the state, Trivandrum Medical College, one of the best arguably, and then going on to do his DNB in gastrosurgery in Mumbai, and then he's trailblazed, been with us for 7 years, amazing surgeon, wonderful human being, and he's been creating ripples all around. Can we put our hands together and welcome our dear Sujith Philip, sir. Over to you, sir.
Thank you, Jacob, for the introduction. I tried to be the MRCP, but many times I don't succeed. Good morning, everyone, and thank you for this opportunity on behalf of the organizers. We have a organization called ASGK, Association of the Surgical Gastroenterology of Kerala, and this is my topic sometime back. We can choose our topics. The organizer had called me and asked, which topic would you like to speak about for the state conference? So this is the topic I chose. Is robotic surgery a pandemic? Because it's spreading all over the world. So I was a strong opponent of robotic surgery. And this is my topic. Is robotic surgery just a gimmick or it's a pandemic? So from that point onwards, now I'm speaking about robotic surgery. So what has changed over the last few years, and that's what I want to expound today. Now, first of all, what is robotic surgery not? What is it not? it is not a robot doing the surgery. That's the first thing. There's no automated thing coming and doing surgery on a patient. That is not robotic surgery. There were some automated systems sometime back in early 2000s, but they never took off, and obviously people wouldn't be very keen on some robot doing surgery on it. So what is it not? It's not an automated robot coming and doing the surgery. So who does the surgery? This is actually a quote from the movie called The Great Dictator by Charlie Chaplin. You the people have the power to make this life free and beautiful, to make this life a wonderful adventure. So the surgery, robo surgery, though the name is robotic surgery, it is done by the surgeon itself. There's no doubt there is no doubt in that. Now there are various systems for robotic surgery. As I said, it can be a completely automated system, which is now not being used, semi-automatic. Now, what is being used now, what is in vogue, is called a master-slave system. That is, a master continues to be the surgeon. So the surgeon will be sitting on the console here. Surgeon will be sitting on the console here, and he will be doing surgery. So it's a surgeon here. The operating table will be here. So this is operation theater. Operating table is there, and we dock the robotic arms. So this is a robo. This is a robo. Surgeon sits by the side of the operation theater, and there is a lab cart, and the anesthetist would be standing at the head end as usual. There are various systems of robotic surgery systems. One is Da Vinci. Then there's a Vertius system, which is British in origin. Hugo, and then there are various other robots which are coming up from China and all, but these are as of now not approved clinically. Da Vinci system, which is being manufactured in US, is actually out and out the most prevalent one, and actually there is no competition for them because they started in the year 2000 and nobody has been able to catch up with them. So most of the presentation about Da Vinci, because almost all the data is from the Da Vinci system. It is called Da Vinci because most of us I heard about Leonardo da Vinci in the 16th century. So he used to create, it was he who had designed, thought about robots thought about robots, and he expounded a lot on anatomy. So that's why they decided to call it the Da Vinci system, based on Leonardo da Vinci. So this is what's been happening the last 8 or 9 years. So if you look at data about robotic systems from 2012, 2013, so when a paper comes out, the data in it will be at least 2 to 3 years old. So if you look out at the reviews in 2012-13, you might see that there's not much data, but now everything has changed the last few years. So we have various systems coming out. There's a Da Vinci Vertius, one in Japan, one in Korea, and so the data has been coming out left and right over the last few years, and that has started getting published now. In fact, so much the number of robo surgery has increased so much that in 2021, 50% of the colorectal cases were done robotically. That's an amazing data. Like 50% of the colorectal cancer cases were done robotically in the United States, and that is how much it has increased. So what are the procedures which can be done by a robo? So these are the list of US FDA approved indications for a robotic surgery. So you can see that it is approved in urology, mainly in prostatectomy. Why prostatectomy? Because prostate is in the pelvis. So when you remove the prostate, you'll have to anastomose the urethra, and that is almost impossible. That's very difficult to do it by hand, very difficult to do by laparoscopy because everything is inside the pelvis. Now, advantage of the robo is its arm can easily go into the pelvis. So that is why prostatectomy came in a big way by doing by the robo method. Other indications are well-known indications are in gynecology, cardiothoracic surgery and general surgery. In general surgery, my talk will be mostly on general surgical topics and mostly on colorectal. So, but we can do various surgeries by robo. That is the bariatric surgeries, colorectal surgeries. We can do hernias, and almost all surgery we can do robotically. So, we'll coming to that. So, main point is that the people who use robo, urology, gynec, cardiothoracic, and general. In the center actually, which I recently went in UK, actually they started doing actually thyroid also robotically. That's also being they go by the transoral route. It's called TOT. But those are just coming up. The main the approved indications are these. So this is how the OT looks. This is a picture from the net. So this is how the OT looks. The surgeon will be sitting by the console on the side. Many of the systems have two consoles, so the surgeon can sit as well as a assistant can sit. This is how the arms are docked. Then I'll just show you the picture how it is done. So patient will be lying here, the anesthetic will be giving anesthesia, the arms are docked. So what do you mean by the arms are docked? So we put in various ports. Surgeons will be aware what is it. So ports are a long metal tube-like things. In robo, they are 8 to 12 millimeter in size. So this is placed inside the abdomen. Then you put in gas inside the abdomen so that there is space to work in. And over that, the robo's arm. Then over that, we put in various instruments which we require to do the surgery. So those instruments are put in through these metal tubes, and to that is we connect the robo arms. Usually there are 4 arms, and to these arms are connected to the instruments which are put inside the port. So this is a video which I took. So this is how the procedure looks like. This procedure of putting the arms into the patient's abdomen is called docking. So this is how we're docking. I open the box. Yeah. So you won't be able to find videos on the net because it is prohibited to take videos in the OT in Western countries. So these are actually all. So that's why you won't find videos. These videos are taken just with the approval of the consultant, but you won't otherwise find videos because you're not supposed to take videos. Anyway, so this is how the docking looks. Now the person in the initial part of the video, this chap who is standing here, this person I'll be coming to in a few minutes. So this is how the docking looks. So we put in all the ports, the metal tubes, we insufflate the abdomen, we put in gas into the abdomen so that we get space to work in. Through the metal tubes we put the instruments, and on the instruments the robotic arms are attached. So there are 4 robotic arms, then they are attached. Then so this is how the surgeon and the assistant sits. There are 2 consoles. So how do we work? So these consoles have, this is how the robotic arms look. So we put our fingers into these things, and when we move our fingers, the robo arms over the table also moves. And we put our head inside the console. So this is so we put our head inside the console. Through this, there is a 3-dimensional view. When we get it's a binocular view. Through this, we can see what's happening. It's a 3-dimensional view, and we also have leg controls. Through this leg control, we can move the camera. The camera actually we had put in while putting in the ports. Camera is also a telescope-like thing which is put into the abdomen that can be moved. We can move the various instruments with our legs and with our hands. And so we just need to move our hands a bit here and there, and the robotic instruments also start moving inside. So that's how basically how the robo works. So this is how the arms look, and so just took a video how the robotic arms will move. So it moves like this, yeah. So when we move our hands in the console, the robot arms will also move. So this actually the surgery being done, and anti-resection or a surgery of rectum being done. So when we move our fingers there, the robotic arms will also move, and that is how the surgery proceeds. Now, there are various instruments we can put inside, and that technology has now improved a lot. So we can have instruments for cutting the various tissues like intestine. They are called staplers. So these are staplers which you use for cutting the intestine. Various instruments. Then for the surgeons, we usually use ICG in laparoscopy. That is possible in robotic surgery, and that ICG is called a Firefly technology. Then other thing is for robo surgery, we have a skill simulator in the. It's a simulator inside the console itself. Many of you would be aware of the simulators which we have done a driving test. Because for many of the driving schools now have simulators. We do our driving on the simulator and then we go for the driving test. In the same way, we have a simulator in the robo also. There are 52 modules where they go from the basic to the advanced surgery. In fact, many surgeries we can do on the robo because they have surgeries for surgery for colon, cancer colon, cholecystectomy. It is all so lifelike because if you cut a blood vessel in the simulation, it will bleed. If you cut the bile duct on the simulation, bile will start coming out. So it's that realistically. So many times by, I would say about 60 to 70%, you will be able to get a skill by working on the simulators. And they grade you. It's not like say, in the simulation after you complete the test, they give you certain marks. Initially you get only 0, then you might go up to 80-90% you can go up, and then they will tell you what all things you need to improve. Your instruments came in during the surgery, you didn't move your proper instruments, or this was used inappropriately. So they grade you. So you can keep on improving your skills even before you start operating the patient. That's what I'm saying. Even before you start operating the patient, with the simulator itself actually, you can improve your skill a lot. So there are around, as I said, 52 modules. So that's possible in a robo. And as I said, there are various instruments, very advanced ones nowadays coming out. And so this is how the instruments look. These are the instruments. So this is the instrument that we put in through the ports or the tubes which I showed earlier. And it is this part which is attached to the robo arms. I had shown the 4 robo arms initially. So this is attached to the robo arms. And so what is so special about robo? Robo, the advantage is the degree of movement that is possible. Our hand can move in 5 degrees movement. 1, 2, 3, 4, and 5. But a robo arm can move 7 degrees. It can turn 360 degree. Any way you want it to turn, it will turn. What is the advantage of that? You can go into very inaccessible locations, like deep in the pelvis. You can take stitches in whatever direction you want to. Deep in the pelvis, you can take accurate stitches. Because you can take accurate stitches because you can turn the arm with 7 degrees of movement. So that is the advantage of a robot. And so because of that, the stitching and dissection becomes very accurate. And also the vision in robo is superior to the naked eye, because we get a magnified view. We can get up to 10x magnification. Usually we would use like 1.5 to 2. Because of that, you can see the nerves and all the small things during surgery, and we are able to do a very fine dissection. So for surgeons in the audience, if you do an anterior resection, surgery of the rectum, removing the rectum, there are various things which you have never seen in a laparoscopy or an open surgery, various structures. And because you are able to see so well, you are able to go in the correct plane, the exact millimeter correct plane you can go. You can spare all the nerves. So that is a advantage of, one big advantage is the vision and the degree of movement. Now, what are some advantages and disadvantages of the robot? The advantages, as I said, is the high resolution 3D view. then the tool and the flexibility, and there is elimination of hand tremors. Everybody has hand tremors. There's nobody who doesn't. So if you stretch out, you can like there's some amount of tremor, and as you grow older, you might get more tremors. So hand tremors are eliminated in robotic surgery, and the ergonomic position. You don't even have to scrub in. For doing a surgery, you have to scrub in, put in gloves and all. But for robotic surgery, if you notice, you don't have to put in a glove or anything. You just directly walk in, do the surgery and walk out. And if you want to take a break during surgery, you go and have coffee and come back. So you can walk into in and outside the operation theatre whenever you want to. That is one advantage. And the patient and the surgeon is sitting, resting his hands on the console. The staff nurse and everybody, they are also sitting around the table. So it's very easy. It's very ergonomic, and we don't get tired. One reason, one problem with surgeons faces is the fatigue when they do surgery. Open surgery laparoscopy all sort of contorted position. But a robotic surgery, even if you operate till night 9 p.m., yesterday morning you are fresh because you are just sitting around, we are just sitting on the console, putting your head inside on a sponge-like thing. So it's so easy. So the ergonomic position which benefits the surgeon, and the surgeon's lifespan is also increased by at least a decade. Otherwise, by 60 years, we'll have to because of laparoscopy. A faster learning curve. Then, because there are two consoles, and we have the simulation software. Then the table itself the table is also provided. The table itself can be moved according to the needs of the robot. And there are 4 arms, as I said. And other thing is actually it has a microphone also. So the person sitting on the console can communicate with the people sitting on the table as well as assistant through a microphone. When you speak into the console, that microphone picks it up and relays it to the operation table as well as the person on the assistant on the console. So communication is also possible. What are these disadvantages? One is the longer operating time due to the patient preparation. That I'll be coming to. Next is the loss of tactile feedback, because that if you touch something, you'll feel like if I touch this, it's hard. If I touch my nose, it's firm. Here it is soft. But that is not there in a robotic surgery. You lose the tactile feedback. So because of that, we won't know the firmness of the tissue which you are casting. So that is why we need simulation. So when I just went there, there was a case, a gynecology case. The ureter was stented, but the gynecologist cut the ureter because she could not feel the ureter, even though the stent was there. They don't have any tactile feedback. I'm just saying that. So tactile feedback you don't have. Now regarding docking, so this person, this is Matt. Matt was the person who showed the docking. Now Matt is I'm just giving an example. Matt is a trained nurse. He's not a doctor. But he's been trained last 3 years to dock properly. He assists all the surgeries. So such an assistant is very important for a robotic surgery program, because he now does, I timed Matt. Matt does docking within 7 minutes. Usually if a post-MS, fresh post-MS person does the docking. Docking means putting all the ports and attaching the instruments. If a post-MS person does it, it might take 45 minutes to 1 hour, and that is what increases the operating time. One main thing that increases operating time. People like Matt, who can be trained, can be a post-MBBS person or a trained nurse, they can be trained to do it quickly. So this guy does it in 7 minutes or even sometimes less. So it is important to have people like him to help. Now other concern is actually ഇതിനിടയ്ക്ക് റോബോട്ടിൽ എന്തെങ്കിലും തനിയെ അനങ്ങുമോ പിടിക്കുകയോ ചെയ്യും. No, the robots now available now doesn't do that. In fact, robotic malfunction is extremely rare, and it's programmed such a way that it shuts down. Whenever there's a problem, it just shuts down. അതിനകത്ത് അത് തനിയെ അഡ്ജസ്റ്റ് ചെയ്യാൻ പിടിക്കാനത്. The whole thing just shuts down, and we have a 24-hour online help is there. We just call them and say shut down. So what do we do when you shut down? Actually, we just remove the ports. That's it. We just remove the ports, and we can either do it laparoscopically or we can convert to open. And when I was there was a case, a very difficult case where some bleeding. It was expected, but when there was bleeding, was not to the robot as such. It's a type of surgery due to the difficulty of the surgery. But we opened in about 2 minutes, just like in a laparoscopic surgery. We are able to undock and open and finish the surgery in just 2 minutes. We are able to open it. So those things are not an issue nowadays. Those things have been sorted out. I think it's in the last 2 years the whole scenario has changed. From 2 or 3 years, maybe from 2020, the whole scenario has changed. Till then, the data about robot was just coming in, and people were not sure. But now there's a lot of data coming in, and people are now started converting to robot surgery more and more. And because of that, people are used to what needs to be done. Now, laparoscopy versus robotic surgery, which is good, as I said. In certain cases, especially in a narrow pelvis, when we go into the inside the rib cage, like gastrointestinal function, there is an advantage for robot, especially in prostatic surgery. This is what I saw actually there, that the number of laparoscopic surgeries has come down drastically in the NHS. Because in NHS is the national health service in UK, the patient's treatment is free. It is a government that buys the robo, and now that all the surgeons are converted to robo. Why are people converting robo? Because it is good for the patient. We are able to see things better, easy for the surgeon also, and cost not an issue in NHS. So number of laparoscopic surgeries have come down drastically, and same thing has happened in US also. So I presume that in these coming years, laparoscopic surgery might really decrease drastically in the next 10 years, just like what happened to open surgeries, because of the said advantages of robotic surgery. Other than the cost, it's better for the patient, better for the surgeon also. The only issue is the cost, and other is the ergonomics. I said the way in which it's being done. So it's so easy for the surgeon, and when the surgeon gets tired, the quality of surgery comes down. So when the surgeon is not tired, the quality of the surgery also goes up. There is a training period. In laparoscopic surgery, you got to at least 25 to 30 cases to become good in a case. For robotic surgery, the learning curve is less. Because it's a three-dimensional machine, we are just using our fingers, and the learning curve is less, and you don't need to be good in laparoscopic surgery to do robotic surgery. The skills are different. So a fresh post-MS person can directly go into robotic surgery. They don't need to train in laparoscopic surgery. If you know how to do open surgery, you will be able to do robotic surgery. And as long as you know how to do the surgery, a surgeon knows how to do surgery, like say a hernia, or we know how to do a cholecystectomy, then you can directly go to robotic surgery. The issue with prostatic surgery is many of the urologists are not very comfortable doing prostate surgery, even open also, so they struggle in robotic also. But for general surgery case, it might not be, and also for gynec also, that's not going to be the case. If they're able to do an open hysterectomy, they'll be able to do a robotic hysterectomy also. Yeah. So what is the single biggest issue with the robot? It is a cost. It's about 5 to 19 crores. Now, in Western countries where the insurance pays for it, that is not an issue at all. So that's why it's picking up more in the Western countries. However, even if you say about the cost, there is a hidden benefit, and that's actually, it's like an iceberg. So though there is an upfront OR investment of 5 to 19 crores, and the cost of the instruments, and the capital cost, the OR time cost, there are many other things, like the length of stay is less. So in a cancer of the rectum surgery, the center, when the patient is discharged on day 2 or day 3, അതായത് ചൊവ്വാഴ്ച ചെയ്യാന്നുണ്ടെങ്കിൽ Thursday or Friday he or she goes home. Somehow the pain is very less. Most of the patients don't go into ICU because there is no blood loss, minimal blood loss. Transfusions are less, conversions are less, complications are less, and the surgical site infections also less because the ports are very small. And so because of these, the cost might not be a concern in these coming years. Just to sum up, there is a law called the law of the rubber band. Rubber band എപ്പോഴാണ് യൂസ്ഫുൾ ആകുന്നത്? വെറുതെ ഇരുന്നാൽ പറ്റുമില്ല, അത് സ്ട്രെച്ച് ചെയ്ത് എവിടെയെങ്കിലും കിട്ടിയാലേ കാര്യമുള്ളൂ, അല്ലെങ്കിൽ റബ്ബർ കൊണ്ട് യാതൊരു യൂസ് ചെയ്യില്ല. സോ അൺലെസ് യു ആർ സ്ട്രെച്ച്ഡ്, you will not perform up to your potential. So whenever we settle for a status quo, let's say നമ്മൾ ഇനി ഓപ്പണിൽ ലാപ്പ് മാത്രമേ, we will not buy a robo. So if we continue in the same status quo, it leads to dissatisfaction. So unless we stretch ourselves and invest in a robo or go to the next technology, we'll be stuck to the past. And so we must be willing to leave behind what feels familiar, safe and secure, and be able to step in. Because robot surgery is definitely the future thing that is coming up. It's not coming up, it's already come up in a big way in the Western countries. As I said, almost 50% of the colonic surgeries are done in laparoscopic by robotic in Western countries. Many of the urological cases are done robotically. And in Cochin itself, actually last week also, the 2 weeks before also, a new hospital has bought a robot. In fact, there are 4 robotic systems in Cochin itself. Small state like Kerala, in a metro city, there are 4 robotic systems. So that is the pace in which it is coming up. And so this is a very popular podcast. I don't know whether it's a surgery podcast called Behind the Knife. Very highly recommended. So in that, actually, one of the famous surgeons of the world called John Cameron was asked, what is the biggest change that you experienced in your life? So he said, the biggest change I experienced in my life is minimally invasive surgery, especially robotic surgery. So change is inevitable in surgery. And unless we change and step into the robotic surgery, we'll be relics of the past, because once insurance comes up, now about many of the NRIs coming here and the people who work in IT coming here, they have insurance. So the insurance company is now taking up the cost. So unless we are able to tap into that protection and pass on the benefit of the robotic surgery to the patients, will be relics of power. They'll all otherwise go to centers which are robotic surgery. So change is inevitable. That's the way the world is moving forward, and I hope we'll be able to move forward in that direction as soon as possible. Yeah. So change is inevitable, and so we'll be able to change the robotic surgery, because that seems to be the future, and that's what I saw when I went there. I'll be happy to take any questions. Thank you.
Thank you, Sujith, for the wonderful presentation. It was very enlightening. Just wanted to know what will be the maintenance cost of the robot.
Presently they are doing it free. When we buy a robot, they send a proctor. There will be someone to guide us during the first 10 to 15 surgeries. For 5 years, actually, we don't have to pay them AMC. And all our surgeries actually recorded live, and it's passed into the center console, and they actually might advise also what is going wrong in our surgery, what is going right. So presently maintenance cost is that much. However, the instruments, instruments are disposable, and however the Da Vinci instruments can be used for at least 5 to 6 cases. So per case, the increase in cost would be around 25,000 for the instruments, and whatever the hospital charges for the robotic surgery per se, maybe 25 to 30,000. So the increase in cost per case probably is going to be around 50 to 60,000.
Thank you.
Yes. Sir, can you please explain about docking? Because in laparoscopy, you either put a varus needle and inflate the abdomen and then dock. Put the port in. In this case, you have to put 4-5 ports.
We put in a varus needle. The MATS puts in a varus needle within 10 seconds. He inflates, and then we put in the port.
And the other ports, like the primary port, you put in varus needle, and then other ports, you put it without vision.
It's the same like in laparoscopy. We put in varus needle, then we put in a OptiView and go in. We put in OptiView and go in, and then the others are put under vision.
Under vision.
In
Okay.
under vision. So.
Sir, one more question. What do you think about augmented reality that is coming up in robotic surgery?
Augmented reality, actually I did, Ajit was here, so we had actually gone to Hyderabad to see the AR. It helps in the training. If you see, augmented, I think you are talking about the simulation programs, so they are available in India. It is useful for training medical students, and also for training surgeons, and it seems to be very good. That seems to work. That's what I experienced. There are various programs, same like in Da Vinci also. AR also has anatomy classes and cholecystectomy and colonic surgery, hysterectomy, everything they have, and seems to be very real also.
Thank you, sir.
sir, for that motivating presentation. So few doubts I have. So thing is that if in UK and US this insurance NHS insurance is covering all those things. So in our setup this private insurances, if we can do a particular surgery in laparoscopically, whether they will cover this thing robotic surgery.
They are covering now. They are started to cover now. So that is why all these hospitals like Rajagiri and Lakeshore have brought a robot. Just Rajagiri bought about a few months back and put in big banners all over from the Dumbacheri and from the Alua. Lakeshore bought 2 weeks back because insurance are starting to cover it. So that's why the cost will go up around 50,000 per case. However, if the person has a 5 lakh insurance and they want to do a surgery which costs around 2 lakhs, adding 50,000 is not an issue.
So laparoscopically for if a cholecystectomy we can do it easily in laparoscopically.
Yes.
So same thing if you try to do it robotically, if queries can rise, right?
The cost will increase.
Cost will
increase by 50,000 for so people who don't have an issue with cost, like people who have insurance, and there are some people who are very keen on robotic surgery because of various issues. They feel it's more accurate. They would do it, and for difficult laparoscopic surgery also, the conversion is going to come down a lot with robotic surgery because the movements are better, and with the Firefly, it is easy to see the bile duct better than the ICG in the laparoscopically. So for difficult laparoscopic colostomy, it will have a role, and for people who prefer to have it, it's like a laser in proctological cases, anorectal cases. People want to do laser. Some people prefer to do laser, and so we give it to them. Some people would prefer to do robotic surgery because of precision associated with it, so we can offer to them if the cost is not an issue.
And few technical doubts I have. What about the fogging thing we are facing in the laparoscopic surgery? What about the fogging?
Yeah, the camera fogging I did not see, but the smoke is there, so there will be somebody sitting around the table who will be opening up and releasing the smoke.
And once if the camera is inside, if it fogs, what will happen?
We can immediately take it out.
But
Yeah, we'll be putting in instruments and taking it out intermittently. We can unlock it, take out instruments, and there are things called robotic suction also. You'll be putting in the suction will be operated by the surgeon, by the person sitting around the table. That is not connected to the robotic console. So we can put in other ports and suck out, or maybe if you want to use it, you can use another energy device to bring down the cost. So those things are possible.
And what about the loading? You told the suturing is easier in the robotic. So what about the loading of the needle?
Same
to the,
like laparoscopy.
So
we put in the suture, and we have to take up the suture with the needle holder.
like that in the lap surgery also.
But just that you'll be able to move the arms, and especially for hernia, anti-abdominal, we can just flip the camera over, and so you can see you can see it very well, because if you flip the camera, you'll be getting such a view, and so it's easy to stitch on the anti-abdominal also robotically.
Okay, thank you, sir.
Nice talk, Sujith. It's an ethical question. So I'll be very interested in knowing what were the contents of your previous presentation before you switch sides.
Yes.
Apart from the cost, of course. Any new technology will have to face these issues. So I would be interested, before the conversion, what were your main reservations about?
Main reservation was the cost, and at that time there was no data showing that robotic surgery is superior to laparoscopy. The results appear to be the same. However, with time now that more robotic systems have come up, surgeons are more trained. More trained. I expect the data come out which will show that robotic surgery is better. Presently, as of now, the data shows that robotic surgery is probably better for areas where you have difficulty in access, like pelvis or GE junction. So it is the data which is now slowly starting to come out, which changed my view. And surgeons are now starting to move away from laparoscopic surgery. In fact, ethical data is important. So I just went through an article in September 2023, the American Journal of Ethics. In fact, some of the standards were taken from there. So they also mentioned that ethically also it seems to be the way forward, now that we have more data which is coming out. When I was preparing the presentation earlier, the data was not very robust.
Good morning, everybody. Thank you. It was Dr. Sujith. It was a very nice presentation. And I would like to tell my experience because this was, robotic surgery is something which has actually become very popular nowadays. And this started, you'll be amazed to find that way back in 2009-10 in Chennai, which was always considered as the health hub, at Chettinad Hospital and Research Institute, where I had the privilege to work for almost 13 years, we had this robotic cardiac surgery going on. So I was like really amazed to find very, very interesting it was, because everything could be like it was just happening there. So they had to invest some 8 crores for this instrument, and the surgeon was trained, like that was the first time in Asia it had come up, and he could do all double valve replacements, CABGs, and all those surgeries. So it was a real experience, and the most challenging part is for the anesthesiologist, as usual, where there are a lot of situations where the anesthetist has to rise up to the occasion, and from cardiac surgery it has moved on to all urological gastro surgeries and all. And now urology procedures like prostatectomy is being done regularly. Now the challenges that the anesthesiologist has to face is, one is that because it is in the initial stages, the long duration of surgery, the positioning of the patient, and once the docking is done, there is no way we have access to the patient. The steep Trendelenburg position that is associated with the surgery. So all this will add on to the challenges the anesthetist has to face, because already you are insufflating causing pneumoperitoneum or inflating the chest. So the intra-abdominal pressure rises a lot. You're giving steep head-down position. The diaphragm gets pushed up. So the organ perfusion gets compromised. So the anesthetic, and moreover, because of the steep position, after the surgery, you will be surprised to find that there will be a lot of facial edema, airway edema, all that. So the extubation becomes very, very challenging for the anesthetist. So fluid restriction is another important thing, where we cannot give fluids just like any other case. We have to restrict fluids so that the edema doesn't happen. It won't be so. It is very challenging because urological procedures are now being done at GEM Hospital, which is there all over South. I think they have a lot of surgical gastro hospital which are specialized in this. So that is the thing. So urological procedures, the result is very good, no doubt about it. And the training is something which we definitely have to have. And the anesthetist also has to be prepared for the challenges that can arise, because there is no way you can intervene in between. So anticipate problems, try to prevent it, and if at all it happens, you should be able to manage it accordingly. So now I feel that though it was so many years ago, I had the privilege to see it right in our country happening, and after that it has spread to many places, and now it's coming up. But unfortunately what happened was there was no one who could take care of the equipment. They had invested so much, did a lot of surgeries, cardiac surgeries using a robotic instrument. But as you had mentioned, one fine day, the equipment just shut down. There was some problem with it, and finally that was the end of it. So maybe 2 or 3 years they could just sustain, and after that it had to be sent back or whatever. We don't know what happened, because the investment was so much those days. So yeah, that is what. So that was one of the biggest challenges, but that was 12 years ago. But after that, definitely it has increased, and as Mr. had mentioned, it is like after 2000, definitely it has improved, and everywhere it is coming up. And in Kerala also, people have started, and Kim's Health Trivandrum, by now they would have got, because in 2021 they were in the process of getting one. So that way it is, definitely it is a field which we all have to be familiar, and that is the thing that is going to be there in future. So the learning curve is something we all have to stick to, and everyone, not just the surgeon, the supporting staff, the anesthetist, everyone is equally responsible for the successful outcome of the thing. So it was a very nice talk, sir. Thank you so much for the...
Just to add on to that, regarding the anesthesia, there it used to be the routine anesthesia in the sense what are the issues we face with the laparoscopically, we face in robotic surgery also. In fact, the pneumoperitoneum, the pressure is slightly less. So there the junior to middle level consultants used to come for the case and they were able to manage. Probably now that the people are better in doing robotic surgery, the learning curve is less, the operating times have come down, and the robotic system is also much better in the last 3-4 years. So they're able to sort out most of the issues. So anesthesia is probably more easier nowadays.
Happen in near future, like common surgeries can be have programmed surgeries in near future or not?
Anatomy is very variable, sir, but AI is going to come up in robotic surgery, and it's going to help the surgeon in pointing out which structures are there. So artificial intelligence is going to come out.
Thank you, Sujith sir, for that wonderful presentation. AI is a scare. AI is replacing all professions, as sir said. So that was my question also. Will deep learning and machine learning take over, and in the long term, will that be a threat to us as a professional? So
Yeah, AI might be added as a tool presently. I spoke with the Da Vinci CEO in UK. So you're saying that they are planning to add AI, which is it's going to help the surgeon, saying that your uterus is lying there or your bile duct is lying there. It is going to help them out. Don't see it taking over it in the near future.
So I'd just like to add on with this AI thing. It just recently Elon Musk had quoted, AI will not replace anybody, but it will replace people who are not using AI. So I don't think it's a threat.
So thank you, sir, for that wonderful presentation. If there are no more questions, we'll close with a thought. The rubber band effect is what I take home from where we are to where we want to be. Always let the tension be there, especially for students. Aim for the stars and have the rubber band effect. Thank you all. Have a wonderful day. God bless you.